Thank you for the opportunity to present. This project was supported by funding from an NIH T32 grant. Readmission is a frequent occurrence after colorectal surgery. It's a marker of negative outcomes, and it has consequences in terms of complications for patients and financial costs for hospitals. Identifying which patients are at the highest risk can help target interventions, such as intensive discharge education, home health, or early follow-up. The traditional approach to creating a predictive model for any postoperative outcome is to use logistic regression, and multiple previous studies have used this technique to create predictive models for readmission after colorectal surgery. This includes the American College of Surgeons Surgical Risk Calculator, which many of us use in practice. Interestingly, while the surgical risk calculator is quite accurate when predicting overall morbidity and mortality, it is less accurate when predicting specific complications such as readmission. Machine learning, or artificial intelligence, is an emerging approach within predictive analytics that has shown promise in multiple previous studies. As stated previously, the traditional approach to creating a predictive model is to use logistic regression, and this works by finding linear patterns in data. In contrast, machine learning uses a variety of different approaches to identify subtle, nonlinear patterns in very large data sets. Machine learning has not been previously used to predict readmission after colorectal surgery in the NISQIP dataset, and our hypothesis for this study was that it could outperform logistic regression. So we used data from NISQIP, including the colectomy and proctectomy datasets from 2012 to 2019. We excluded patients who were missing data on readmission, who remained inpatient at 30 days, who died before discharge, or who were discharged to a separate acute care facility. Our primary outcome was readmission within 30 days postoperatively, and our models incorporated 113 different predictors, ranging from preoperative characteristics to postoperative complications. We split our dataset into 3 parts: a training set for model development, a validation set to adjust model settings and to ensure generalizability, and a third test set that was held out to calculate evaluation metrics. We used data from 2012 to 2018 for training and validation, and data from 2019 was held out as the test set. We applied 3 different machine learning modeling techniques and compared them with logistic regression. The first 2, called random forest and gradient boosting, work by combining many decision trees, while the third, called neural networks, also known as deep learning, processes numerical data through a series of nonlinear functions that are adjusted with training. We assessed each model with a variety of metrics. The first is called area under the receiver operating characteristic curve. This is based on a plot of the true positive rate versus the false positive rate. It ranges from 0.5 at the worst to 1 at the best. And the closer this curve is to the upper left corner, the more accurate the model. We also use area under the precision recall curve. This is based on sensitivity versus a positive predictive value. This ranges from the rate of the positive class at the worst, in this case the rate of readmission, to 1 at the best. And for this curve, the closer the curve is to the upper right corner, the more accurate the model. We also calculated sensitivity and specificity across a variety of thresholds, and we used something called SHAP, or Shapley additive explanations, to identify which variables within the dataset had the strongest influence on model predictions. In total, our dataset included 260,000 patients after 13,000 were excluded. About 200,000 patients were used for training and validation, while about 50,000 were held out for the test set. And in total, about 28,000 or 10.9% of patients were readmitted. In terms of area under the ROC curve, neural networks performed the best with a score of 0.855. This was significantly higher than logistic regression at 0.725, while gradient boosting and random forest performed similarly to neural networks. As you can see in the curves to the right, all of the machine learning-based techniques are much closer to the upper left corner compared with logistic regression, indicating improved performance. In terms of area under the precision recall curve, neural networks again performed best with a score of 0.603. Again, this was significantly higher than logistic regression, and random forest and gradient boosting performed similarly to neural networks. Again, in the curves to the right, the machine learning-based techniques are all much closer to the upper right corner compared with logistic regression, indicating improved performance. So in summary, all machine learning-based techniques performed better than logistic regression, but neural networks performed slightly better. In order to translate these metrics into numbers that we understand as clinicians, we also calculated sensitivity and specificity across a variety of thresholds for the neural network and logistic regression models. And as expected, as specificity decreases, the sensitivity for both models increases. But as you can see, at each level, the sensitivity for neural networks is higher than the sensitivity for logistic regression, indicating that neural networks have both improved sensitivity and specificity. At a specificity of 90%, neural networks have a sensitivity of 63.5% versus 41% for logistic regression. At a specificity of 50%, neural networks have a sensitivity of 90.9% versus 81.8% for logistic regression. This chart shows a ranking of variables within the dataset based on their influence on model predictions, and this was using the SHAP values that I mentioned earlier. The most important variables to the models were postoperative ileus, index admission length of stay, organ space surgical site infection present at time of surgery, ostomy placement, ASA classification, and operative time. In conclusion, the current machine learning models show improved results compared with logistic regression, as well as previously published studies. We did have certain limitations. We did not perform external or institutional validation, which is essential to verifying model performance prior to clinical application. And these models are also cumbersome to use clinically. They incorporate too many variables to enter by hand into an online calculator. This could be addressed by incorporating them directly into the EHR, which could provide real-time predictions based on up-to-date data. We believe that this could form the foundation for a smart EHR that assists clinicians in targeting interventions to reduce readmission after colorectal surgery. Thank you, and I'll be happy to take any questions.